Now, debate number one will be, as I discussed, controversial bunionectomies. We'll focus on the minimal incision, Lapiplasty, and opening wedge. And we're going to start with Dr. Kaplan. And the case that we're all focusing on is this. A 50-year-old woman who lives in Beverly Hills. She's only 5'2" and works in fashion retail. Her bunion hurts even in sneakers. It's been there for years. She's failed shoe modification. She's unable to wear heels. She wants surgical correction, but she's very confused, as she's gotten many different opinions on what to do from an operative point of view. Her IAM angle is 15 degrees, and it's important to note she has no hypermobility and she has no arthritis in any joints. Our first speaker on this will be Dr. Kaplan.
Okay. Hello, everyone. My name is Jonathan Kaplan, and I'm here to discuss minimally invasive bunion correction and hopefully convince all of you why it's here to stay. A quick thank you to the California Orthopedic Association, Dr. Pfeffer, and the rest of my panelists for including me on this great topic. To get started, I have no current disclosures, although I have been an instructor on this in the past, and that's important to consider when discussing. So I think this patient's particularly a great candidate for the minimally invasive procedure, and I'm going to try to tell you why. First of all, minimally invasive surgery in general is orthopedic surgery. Minimally invasive is great for bunion surgery. I'm going to go over the history, what my experience has shown, and what the data has shown. And then I'm going to talk about the common knock or misconceptions of MIS bunions and try to explain why they're wrong. And hopefully by the end, you'll conclude that it's a great option for this patient. So just like the rest of orthopedics, we can say my open procedures do fine and all these other options are great options, but let's look at some history in the other fields of orthopedics. So in sports, we've seen a progression towards minimally invasive, in the hand, in trauma, in spine. So why not foot and ankle? So what are we talking about? Well, we're not talking about the first or the second generation procedures. These have been shown to have poor outcomes as they lacked optimal stability. We're really talking about this third generation in which the key is stability in the screw fixation. It's an extra articular osteotomy, which minimizes stiffness, and the screw fixation is important to be bicortical so as to prevent recurrence and optimize construct stiffness and early recovery. So my easiest argument would be, why would you want this when you can have this? It's less pain, less swelling, less stiffness, and lower rates of wound issues. It's a quick recovery. The surgery takes about 30 to 45 minutes. Your weight bearing is tolerated in a post-operative shoe immediately for about 4 to 6 weeks. The bandages come off at about 1 to 2 weeks when we start motion. You're in a regular shoe by 6 weeks, running at 8 weeks, and back to normal by 3 to 6 months. But don't just take my word for it. There's good data that supports it. I'm not going to go over all the data for the sake of time, but I picked a few that I think are important. This is a great level 2 prospective randomized study looking at open versus MIS. They looked at moderate and severe bunions, which is pertinent to this patient. They used a transverse osteotomy and showed that it was stable. There were equal outcomes and not surprisingly less pain in the early recovery. Another study that compares mild, moderate, and severe, and again, it shows equal outcomes with less pain and even had a shorter surgery. I could go on and on about data. There's more and more studies showing mild, moderate, and bunions work. This study looked at all these and showed excellent outcomes, low rate of recurrence, and they concluded it was safe and effective. The list goes on. There's cadaveric studies, there's short and long-term studies, and my point is that there's data that really supports this and data that backs it up. So what are my opponents going to say? Well, MIS is only for mild cases, but this isn't true. In my experience, and the data shows it's good for mild, moderate, and severe bunions. So this patient who has a moderate to severe bunion would be a good candidate. Some would say that you can't control the rotation, but you can do a chevron or a transverse osteotomy. In this patient, their sesamoids are a bit uncovered, so I would do a transverse osteotomy, and this would allow good control of that rotation. And again, this is stable as evident by that study I cited. Some would say you can't correct the DMAA, but I'd actually argue you can correct it more easily with this procedure. You can do a medial closing wedge, whereas with the proximal osteotomy or the lapidus, you're going to have to make a separate osteotomy if someone has an increased DMAA. Some would say that you can't balance the soft tissues, but you can do a percutaneous lateral release with a beaver blade. I'll often do this after the osteotomies to really dial in the correction. And I would also argue you're not disrupting that medial capsule there by not weakening this. And then the last critique that I frequently hear is, well, you know, it's probably just too hard for me to learn. I'd make the argument that as with anything else, there is a learning curve, but it's not impossible. I use the analogy of open rotator cuffs. No one is doing these anymore. Everything else is arthroscopic now. So my conclusion is that it works. Don't deviate from the rules. So this patient does not have hypermobility. They don't have a congenital deformity. There's no arthritis. I think they're a great candidate for it. I would encourage everyone to embrace change, and your foot can go from looking like this to looking like that. So I think it's a great option, and the future is now. Thank you.
Has become has come under the focus now of bunion surgery and its role in getting an excellent correction. Dr. Friscia.
Correction of moderate to severe hallux valgus with the lapidus type procedure is an ideal procedure for the bunion that you pictured. And again, the bunion you pictured is more than the typical Beverly Hills bunion that you might be operating on. And this procedure is reliable and reproducible. Lapidus was one of the first to note increased mobility of the first ray in certain patients, and he advocated the first cuneiform metatarsal arthrodesis. Ken Johnson could actually show that if you wrap the foot, you could correct the IM1-2 angle in patients, and he would perform a lapidus type procedure for that. Now, as Glenn said, there's over 100 bunion procedures, and that's because none of them are perfect and work real well, or work reliably well for all doctors. With the typical distal soft tissue procedure with proximal osteotomy, that was popularized by Roger Mann and Mike Coughlin. However, there's lots of complications: 28% risk of dorsiflexion of the first metatarsal, risk of transfer metatarsalgia, a risk of hallux varus. There's other procedures, a proximal chevron, double osteotomies, all these because people have had problems with the procedures and there's a high rate of recurrence. The key to the derotation is that you can see with rotating the metatarsal, you get quite a bit of correction. Now, this, you may say that this is an unstable first cuneiform metatarsal joint, but in any case, with rotation, the sesamoids go into alignment and you correct the deformity quite well. And so this is the key of the frontal plane deformity. With most bunion procedures, there's a high recurrence and potential complication rate. It's well documented, and many studies with the scarf procedure and other ones show a 25 to 73% recurrence rate or complication rate. And the risk factors for recurrence have been shown to involve when you do not approach the rotation issue. So if you don't reduce the sesamoids, a 10 times chance of recurrence. If there's a lateral round sign indicating pronation, 12 times risk of recurrence. And with the traditional assessment in the 2D X-ray, you look at it, you look at the sagittal plane, and you measure the angles. But what about the frontal plane? That's where much of the deformity may be occurring. And as you can see here, these sesamoids, are these sesamoids subluxed, or is it just the rotation? And so once you get the sesamoid view, you see it's really more a rotational problem. And multiple studies have shown that hallux valgus is a three-dimensional problem. The pronation significantly contributes to many of these patients, and that's been ignored in the past. And with 80% of bunions have a frontal plane rotational deformity, and 22% of these have an average degree of 22-degree average frontal plane rotational deformity. You can see these varying degrees of rotation or even subluxation of the sesamoids as the rotation gets worse. So on radiographs, you can see the lateral round sign indicating the condyle and indicating rotation. The apparent lateral displacement of the sesamoids when it's really more rotation. And these are all consistent with pronation. And you can see the X-ray of the normal bunion of a normal foot, and then with rotation, moderate rotation, the sesamoids are off a little bit, and then with significant rotation, the sesamoids may not be truly subluxed, but the metatarsal is just rotated. So the anatomic center rotation is the first tarsometatarsal joint. That's where the deformity is occurring. The metatarsal's not crooked, it's not deviated, it's not deformed. So after an osteotomy, you're cutting at a different area. You're not restoring the normal anatomy and potentially predisposing to recurrence. So that's the key to this procedure. So in this case, what we're doing, we're sacrificing the pathologic joint where there's either rotation or instability to preserve the functional first metatarsal phalangeal joint. A lot of these other procedures can predispose the first metatarsal phalangeal joint to arthritis and problems in the future. The tarsometatarsal joint has very little motion, and fusing it and stabilizing it can solve the problem, as these X-rays shows. And the key to the new equipment that's around for the lapidus type procedure, there's several companies are doing it now, indicating that it's probably successful because some of them have copied it. And there's new devices out that make a reliable way to do it. And you can actually correct before you cut. So it makes it easier than when you used to cut and then correct to try to put screws in and things like that. So you can see this procedure with the rotation, you correct it, and then with 2 plates, you have stable fixation, you're weight bearing immediately. This is one of the cutting jigs that's used that achieves the good correction fairly soon. And you can, these jigs hold it, they're reproducible, you make the cuts, and then you put the 2 plates on. Just like with MIS, you're able to weight bear immediately. The patients recover in 4 to 6 weeks. The pain is not bad considering, and the recovery is good. And it's a reliable, reproducible procedure. So when you look at these x-rays, I mean, the procedure on the left looks somewhat archaic. The fixation doesn't look that good. You know, if you do it right, if you do it well, I mean, it could be done well and it's okay, but it looks archaic. And you look at the right procedure, that's modern orthopedic surgery. That's reproducible, that's stable, and high patient satisfaction, high reproducibility, and I think a great procedure and a great solution to the bunion you pictured. Thank you.
All right. Thank you, Dave. So let's see here. Okay, so you can hear me now, Christy?
Yep.
Okay, good. All right, well, those are excellent talks. After I heard the talk on MIS, I wanted to go out and do it. After I heard Dave's talk, I thought MIS was ridiculous and I wanted to do MIS. And I wanted to do a lapiplasty, but let's just keep in mind that really the jury's now out on any of these. And I think the most important thing from this entire session is who made up the word depronation anyway? Okay, so I have no conflicts to speak of. I just do want to share, though, that I do have an interesting conflict in that on Saturday, I had an ankle fracture. I actually dislocated my ankle doing something stupid around the house. I was operated on Sunday by Milt Little, one of my trauma partners. And we're going to see how I do with my talk, having taken a Percocet and lying flat in the bed. I've never given a talk with either of those circumstances, so maybe cut me a little slack. Okay, now I just want us all to keep in mind that there are many things over the years that become trendy over the centuries that are well accepted. Bloodletting, for example, the Concord metal-on-metal hips. All of these things have been highly accepted, and yet somehow they've faded from grace over time. There's a big movement in the country now for MIS. It's very popular. There's a lot of undercurrents. If you look very carefully down here in the right of this picture, you'll see actually Dr. Kaplan's face at this rally. You see it down there. I'm not sure I can point to it or not. This is a recent rally from a lapiplasty group. And here I think you can see the person in the hat dancing is Dr. Frischer. So there's a lot going on that we don't know about regarding MIS and minimal incision and lapiplasty and promo. A lot of it supported by different groups that we have to be cautious of. Now, if MIS works, I think it's terrific, but rotation. I think this is a patient who's having a lapidus. This is intraoperative. You can see the correction that occurred from just closing the IM angle. Very little correction occurs from rotation. I think rotation is important. I still want to know who made up the term depronation. It's ingenious. And I just don't think that that's an important component. So I've done my rebuttal to Dave and Jonathan's talk. They'll do their rebuttal to mine, and I'll give my talk now. Proximal opening wedge, it's something I've been doing since about 2004. I think it's a beautiful, elegant, and simple operation, which is why I keep doing it. There's certainly any operation that I can do, or I'd be allowed to do at Cedars. The surgery was gaining traction in the United States through 2003, 4. I was doing these when I first arrived at Cedars in 2005, but then all of a sudden, an article came out of HSS from my good friend Scott Ellis that talked about a high recurrence rate. It was only 17 patients, and really this caused the operation to sort of fall off the grid. And people kept quoting this on how there's a high recurrence rate. I've not found that, but certainly really that is the literature to date. 3 or 4 articles touting it prior to this, and this article, because of the power of that research group, it really ended it. I'll just show you some of the technique that I used. Like any bunion, you need to get the cut in a proper alignment in every plane. In this case, which I don't think is done with the minimal incision surgery, we'll always release the adductor, rupture the capsule, and free off the sesamoid superiorly. I'll also divide the transverse metatarsal ligament. I think this is a key operation, a point of any operation to sustaining a good result and reducing your sesamoids. This is a very important picture because it's showing what Roger Mann discussed with the modified McBride of sewing the first and second metatarsal capsules together. The transverse metatarsal ligament's divided, and by sewing the capsules together, it recreates the transverse metatarsal ligament. It probably scars in and heals in that position. And interestingly, if you think about it, because this incision is being put dorsally, it also depronates the first metatarsal. So depronation is important at all. It's occurring when this suture is tightened. The proximal cut has to be made in perfect alignment under cool water irrigation. This operation also never gained a lot of traction because it was done in such a difficult way. I think some of the people who presented this for the company initially may never have done this operation. It was discussed as with an oblique cut and a lag screw and using osteotomes to spread the osteotomy apart, which only led to easy fracture of the lateral cortex, which has to be kept intact. Simply pressing the metatarsal heads together opens up the osteotomy nicely. You can gently use traction of an osteotome, but I don't advise that. The plate's applied, you can change it. It's a wonderful operation for a perfectionist like I am, and I would hope that any of the presenters are, because you can change the intermetatarsal angle perfectly depending on the size of plate you put in. It's a very malleable plate. It's only 0.5 millimeters. And again, I want to emphasize, I have absolutely no conflict of interest here. I just think this is one of the most beautiful operations in all of orthopedics, which is why I wanted to talk about it. The plate's placed, the lateral cortex is kept intact, and then it's filled with finely ground cancellous chips. I used to be very nervous about applying cancellous chips, but I've not had a problem. I've not had a non-union of this, except I've had 2 hallux varices and 2 plate removals in very thin people. Remember also, this incision, although it is a big incision, is done right along the margin of the glabrous skin. And I would say this incision disappears completely in the same way that the minimal incisions do. So there it is, high intermetatarsal angle, a beautifully correction, perfect reduction of the sesamoids. And if need be, other components can be made to correct where there's deformity, if it's a DMMA or a lapidus or an achin. Not a lapidus, but or an achin. And I just put this slide on the right on patient RZ is, what's wrong with doing a simple lapidus with 2 screws? I don't personally need a complicated jig to depronate my lapidus. It's something I find I'm able to do myself. That's it. Yield to common sense. Thank you very much. And we can have some questions now from our audience. Winning here anymore is the answer, because the medial incision that I use, it just disappears. But do you make what's the importance? And I don't know the answer to this. What's the importance of a intermetatarsal incision for the minimal incision? You know what I mean, for releasing the sesamoid and all that. And would you add that? And then what's the risk of AVN if you add that, or something like that? And then Dave, why really? Maybe you said it. I was concentrating on other things, and I'm a tiny bit out of it. But why really not just depronate it the way I do? I guess we you know, I do that with my my lapidus, you know. But I think those are the interesting questions. I really. Does anyone else have anything they want them to put in their rebuttal? We can do it this way. Are there other things you want them to address? Tim, did you have something?
I'm curious, how do you change the surface in the MIS? How do you take what appears to be essentially a chevron osteotomy and a translational push and rotate it around while still maintaining overlap?
Okay, so we're not being recorded now, right, Christy?
So I think that those were both great talks, and understandably, it's hard to argue with those points brought up. I think my rebuttal to each procedure would be that for the lapidus procedure, and whether it's done with the traditional lapidus or with the lapiplasty, there's still the known risk of non-union, and when that happens, that can be quite a hard complication to deal with that has a significant amount of long-term effects. So that's, I think, one of my limitations with the lapidus procedure. I still think that the majority of bunions can be done with the MIS procedure, but the lapidus procedure can be kept in my back pocket for when I need to do it. I think for the proximal osteotomy, there are complications with it as well, risks of dorsal malunions and transfer metatarsalgia, and the complexity of it also leads to the complications having more long-term effects as well. So that tends to be the main reason why I gravitate towards the minimally invasive procedure. And again, you can really correct a lot of the deformity. As my practice has expanded, I have focused more on how to correct the translation, how to correct the rotation, and how to correct the articular angulation. I think all of those are important, that 3-dimension that all of us are talking about. That's where the transverse, that straight osteotomy really comes into effect, because as you translate the head, which you can do with a shifting device, you can also manually rotate the hallux, and you can actually rotate the sesamoids and rotate the hallux metatarsal head to correct that rotation. You can also lever on the metatarsal head if you put a K-wire in as a joystick to correct the DMAA. So the key is that as you learn the technique, you can learn these advanced maneuvers that allow you to correct all 3 planes of the deformity still through a minimally invasive technique.
Dr. Frisha?
Moderate to severe bunion deformities can be difficult to correct, and the key, I think, to the lapiplasty type procedure is that it's reproducible and reliable with a low chance of recurrence. Now, the proximal wedge opening osteotomy is a great procedure, and I did that for years. You know, key to that is that you have to do a good distal soft tissue procedure like Glen showed, and repair that capsule and move the sesamoids over. And if you rotate with that and do it well, I mean, that procedure works. As you can see, that's kind of the opposite of minimal incision surgery. That's a big incision medially, a fairly big west face incision, and a fair amount of surgery. Those actually surprisingly heal well, but with the bone graft, and you know, it's not a bad procedure, and you know, I think it usually works. But like any distal soft tissue procedure, there's always the chance of hallux varus and I think a greater chance of complications. The minimal incision surgery, if you say there's a chance of non-union in the lapidus, the key to the modern jigs and devices is that the chance of non-union is less because you're not making freehand cuts. You're making reproducible cuts. You have compression devices. And you have stable fixation. That's why you put 2 plates on. And so the risk of it not healing is fairly low. And I think the risk of a non-union in MIS surgery, where you're putting in 2 screws and have very little bony overlap, it can be much greater. So that's why I think the lapiplasty is a much more reliable procedure. The cost of a lapiplasty, some of these new devices, as like any newer device, they can be more expensive. Surgery centers obviously can negotiate better rates for them sometimes. The key to it too is that it's a first cuneiform metatarsal arthrodesis versus an osteotomy that actually reimburses more. And I think most surgery centers find that their increased reimbursement compensates for most of the increased cost. So, and again, there's less of a chance of recurrence, at least in my hands, and I think the studies show. So it's again, people should do what they do best, and but I think this really approaches the main deformity of bunions and is a reliable correction. Thank you.
All right, thank you very much. We're going to now go on to our second debate on Lisfranc fracture.